For the last presentation, I'm going to be speaking on psychopharmacology. Just by background, I'm a child psychiatrist and a psychopharmacologist, so definitely been working in the area of medication development and analysis of existing data sets, and also a clinician in our clinic. I work with Tom Spencer, Joe Biederman, and others. We have, I think, 1,800 kids that we follow. I follow about 500 children and adolescents. Many of them have ADHD, bipolar, substance use disorders. So what I'm going to be doing is giving you a bit of a fundamental overview on pharmacotherapy issues. Certainly fill out your question cards or come forward with questions that you may have regarding that. This is more of a primer, and certainly happy to discuss further at any point, or if you see me at the meetings, to discuss more in-depth issues here. The presentation is intended solely for healthcare professionals, educational, non-promotional purposes, and may contain references to products and indications that have not been fully approved yet in Italy. And for information, a copy of the product monograph, please consult the manufacturer. And also by disclosure and also by thank you, I wanted to thank Eli Lilly for underwriting and helping to organize this symposium. In the end, the materials that are presented are by the lecturers themselves, with the understanding that things have to be fair, balanced as usual in these types of arenas. Also, I think it's particularly relevant to my talk, since I'm talking on psychopharmacology, that I work with a number of pharmaceutical companies on the development of new medications and extensive use of existing compounds, such as the ones listed: Abbott, Glaxo, Lilly, McNeil, Neurosearch, Novartis, and Shire. The funding from my laboratory comes actually from the majority of it comes from the National Institute of Health, the National Institute on Drug Abuse. Do a lot of work on substance abuse overlay and ADHD and in bipolar disorder. In terms of integration, I think that most people realize that medications are typically used in context to a multimodal approach. There's many different venues that need to be addressed, including support groups. In the U.S., we use CHAD. There's ADIS. In the U.K., there's a growing support groups that are absolutely indispensable for children and adolescents, their parents. Adolescents actually love to go on these websites and chat with other adolescents or learn a lot about the disorder, as well as adults who have the disorder to understand it. And there's many more support groups now that are available through chat rooms on the internet. And so most adults need some point to be really able to ground themselves in understanding these conditions and what's been wrong with them, and many of the things that you've heard previously. Education you've heard about, the assessment, involvement, psychoeducation to actually involving and mediating the environment. Coaching and organizational skills. There's some interesting research underway now for very specific manual-driven organizational skills in both treated and untreated children who have residual clinical evidence of executive function problems. The secretary in their brain is simply not working properly. There's parent training you've heard about, and then psychotherapies, again, that you've heard about, some effective, some not effective. We've been working in the one that you heard from Dr. Young, from Dr. Safran and all has worked with us in the development of very specific cognitive behavioral therapies in medicated adults with ADHD. Medicated seems to be much better success in that group. There's been a series of earlier lectures on the multimodal treatment study of ADHD. This is an older slide now that reminds you that there have been studies that have looked at the role of non-pharmacologic, pharmacologic approaches to combination. In general, all the children did well at 14 months in this first phase of this study. There were some benefits, though, to multimodal treatment. For example, specific groups such as anxious ADHD children. And a subsequent publication, something that I'm becoming much more interested in terms of pharmacotherapy, and that is our children are better with pharmacotherapy. You'll see those data. But as Dr. Young showed, there are not total remission from the disorder, so they have residual symptoms. And residual symptoms of any psychiatric disorder lead to relapse, continued functional impairments, and sequelae that occur over time. So in the MTA study, they showed that there were more children who were well, who were normalized, in the group that received combined pharmacotherapy plus this very elegant behavioral therapy program. Some signal that, in fact, we need to do better than just using a medication, or we better optimize our medicines better. In this study, the medicines were optimized pretty well. They spent a great deal of time doing that. This is now the very recent 3-year data, and I'm not sure how many people heard the presentation, but this was presented earlier in the meetings, and basically showing that over time, it's a bit confusing because it looks like all the lines come back to join each other, and in fact they do, that if you look now 3 years out after the original interventions, that the children are doing better as they grow up, and that's a good thing. Not as much separation as one would have expected. Some of that is thought to be because the children, some of the interventions were stopped, and if you stop an intervention, you'll get a relapse. And many of the children just stopped treatment altogether. And one of the things we're not addressing here that we should be probably addressing in greater detail is adherence to treatment. In the United States, for example, if you look at adherence to treatment over time, although the numbers vary, anywhere from 60 to 80% of children on medicines for ADHD are no longer on those medicines at 1-year follow-up. So it's a problem to just write a prescription and send a child off. Better adherence when people, the families, and the children know that the ramifications of treatment, the need for treatment. Better adherence if you have more frequent visits and more of an alliance or a therapeutic relationship with your patient. The medications that are used in ADHD include the stimulant medications, and here we have listed those that are approved in over one of the European countries: methylphenidate, dextroamphetamine. We also have atomoxetine, which are approved, and then a number of agents that have been tested. Some are in development, some are no longer being further developed, but still have empirically based data to demonstrate their effectiveness compared to placebo in the treatment of ADHD. Now, I'm going to be talking more about pediatrics here, but I'm happy to comment just a bit on adult ADHD. Most of the data I'm showing you applies to adults like it does to children. Even though we don't have it on ARS, I'm just interested in a show of hands. How many people are treating adults with ADHD right now? How many people are treating adults with ADHD? Do we have That's it? No? Okay. Thank you. Okay, well, hopefully I'll convince you that, at least if you're thinking of medication, that the medicines we're talking about for pediatrics also work and have been tested for adults. The medicines we use for ADHD, we know a lot more about how these medicines work. Names like Nora Volkow from the United States, who's the director of NIDA, but also colleagues like Tom Spencer have done some work that show us that the medicines we use for ADHD work by binding to this area called the transporter. Under normal conditions, what you have is the nerve impulse, the migration of the nerve impulse, and these packets of neurotransmitter, dopamine and norepinephrine in particular, that then are released into the synapse here and then go across, bind to the postsynaptic receptor, and then potentiate the signal. They're taken back up through the transporter. That's an efficient way to use a neurotransmitter. It also dampens the signal. If you block this transporter, by blocking this transporter, what you'll have is more of an accumulation of dopamine or norepinephrine. We know a lot more about dopamine than we do norepinephrine. We know, for example, that methylphenidate blocks and increases the amount of dopamine and norepinephrine. Other medicines, such as atomoxetine, the tricyclic antidepressants, imipramine, amitriptyline, bupropion, work also by blocking the transporter, but have more mixed effects on dopamine and norepinephrine. One of the points is that our medicines don't work directly here, postsynaptically. If you give an antipsychotic for bipolar or for psychosis and schizophrenia in childhood, it works over here. But the medicines we use are indirect acting in so much as they work with the natural machinery of the cell. It's also important to realize, to tell parents at least, that well, you may prescribe methylphenidate. I've never seen methylphenidate jump up and do somebody's homework. The child has to be instructed and there has to be supervision around it and the structure provided for the child then to complete tasks. The good news is we have lots of new stimulant medicines to help treat ADHD. The bad news is we have lots of new stimulants to help treat ADHD. This has become overwhelming. This is the laundry list of different agents that are available in the United States and many of them in Canada now to treat ADHD. The ones listed in the yellow are the ones that are currently available in the European arena. We have everything from beaded technologies to pills to patches to prodrugs. And it's becoming really quite difficult to keep these straight. For example, these listed here are methylphenidate class agents, and these listed here are amphetamine class agents. And what I'm going to do is to walk you through a bit about some of the similarities and differences, but more or less sort of what we know about some of the short and longer term outcomes using these using a couple of them as sort of prototypes for the other ones. We think that methylphenidate agents are going to work largely the same and amphetamine agents are. We know that in talking about stimulants, they work not only on the core symptoms of ADHD, as you heard earlier about the differences in the different symptom clusters, but also work on very important secondary outcomes such as compliance, impulsive aggression, not predatory aggression, not stalkers or predators, but kids who lose it, who have just non-specific aggression. They improve socialization. They increase what we call the hierarchy in the classroom. The child actually moves into a higher pecking order in the classroom. They improve the academic efficiency and also accuracy, probably more efficiency as well as productivity in the classroom. This is the first generation of the extended release stimulant class agents. This is the OROS, the osmotic release oral system. Methylphenidate, this is, for many of you are familiar with this, a capsule that has an overcoat of methylphenidate, a polypropylene plunger, and as you go through the GI tract, you have water that can permeate this membrane, expands this polypropylene plunger, pushes a chemical gradient of methylphenidate through a laser-drilled hole. And what I want to point out is, if you look through the day, this is looking at scores on ADHD. Higher scores are worse, lower scores are better. And this is the hours after you give the initial dose. This is done in a paradigm that was developed sort of jointly by Bill Pelham and Jim Swanson and the Weigels, where they developed a classroom, an intense classroom observation where you can follow children and examine how they are performing in multiple domains through the day, both in an unmedicated and medicated status. So you can look hour by hour. You can do blood levels. You can do weight, height. You can do a whole number of different things that help you understand what's occurring. Point number one is, if you look through the day, there's, first of all, almost all of these studies show the same thing, a decay in ADHD symptoms through the day. The children naturally get worse through the day. If you give them treatment, in the red is 3 times a day regular methylphenidate, and in the yellow is the once a day extended release methylphenidate, you can see improvement. So this is one, I show this slide because it's one of the new kinds of technologies that's called an analog or laboratory classroom that's used to map out hour-to-hour changes in ADHD outcome, but to also show that how these medicines stack up to short-acting medicines. They really provide about 25% better coverage through the day given equipotent dosing in terms of outcome. Now, if you're using any of the methylphenidates, and I need to say that the original data from the multimodal treatment study using 3 times a day methylphenidate showed a very similar phenomena, and that is that, first of all, as you dose, and this is a child that is well dosed on the medicine, if you look over the months of the study, and this year over 400 children followed for up to 2 years, you can see that there was an increase in the dose of the medicine that was necessary, about a 30% increase in the dose of methylphenidate through the day. And here's the actual milligram per kilogram dosing also listed here. If you look at the milligram per kilogram dosing, notice that it increased over the first year and then leveled off. So what does that mean? It means that you actually are increasing the dose relative to the size of the child over the first year, and after that, the increase in the dosing of the medicine just keeps up with the child's body weight as they grow. There appears to be a tolerance that develops to methylphenidate. In the MTA study, they found about a 26% increase. We found about a 30% increase. So it shows you that they line up pretty carefully. Expect to increase the dose of the medication to maintain effectiveness over the duration of the treatment. Such is not the case in terms of a tolerance, such as showing here, if you're talking about the 2 other approved products, amphetamine products, or if you're thinking about using atomoxetine. Both of those long-term studies do not demonstrate that there's a tolerance that develops to the medicine. Let's shift to one of the newest extended release, which I'm showing to tease you because it's my sense is that you'll be seeing this moving over to the European arena, and it's a very interesting next generation stimulant. This is called lisdexamfetamine, LDX. Its trade name is Vyvanse in the United States. And what this is called a prodrug. This is an amphetamine prodrug, D-amphetamine, and here's the D-amphetamine right here. What happens is you have a lysine that's linked to amphetamine, and as that goes through the GI tract, you have probably a peptidase. I still haven't been sure exactly what it is, and a hydrolytic reaction that splits off this lysine to unappreciable amounts. There's very small amounts of lysine, and then the amphetamine. So why is that important? Because this reaction is very slowed. If you give this intravenously, you essentially see no high compared to the D-amphetamine. If you do it intranasally, because the prodrug is there and the prodrug is inactive, you essentially have a diminished high or euphoria. And in rat models, if you give overdose of this, you can't saturate enough to cause an overdose because it doesn't get absorbed and you don't get appreciable amounts of D-amphetamine to cause damage. So this is interesting because you may see this for other stimulant medicines. This is going to have appears to have a lower abuse liability, particularly in the substance abusers. I think for normal ADHD kids, it's a low abuse anyway. But as I'm going to show you later, there is some concerns about misuse and diversion of these medications. And if you look at its effect, you can see it works for both behavior or deportment and for inattention, similar to existing amphetamine called mixed amphetamine salts. There's many controversies that exist with the stimulant medications. One of the greatest is the weight consideration, and this is long-term data with the Oros technology. And want to show is, and this seems to be the case with all of the medications we use for ADHD, and show this data because we published it previously a few years ago. And what you see here is that for the first 6 to 8 months, there's no weight gain that you see. So there's a relative, if the kid's growing height-wise, you actually see the body mass index fall with these medications, so the kids can appear thinner. Expect for the first 6 months of treatment with stimulants that you don't have weight gain, and such is the case that I'm going to show you in a second. However, with this compound, this once-a-day osmotic system, what you see is linear height through to 24 months. In fact, at the end of it, compared to where they would have been, it may have been around 0.2 centimeters deficit relative to where they would have been, 0.2 centimeters. So a real negligible, if any, growth in height deficit. If you look at the MTA data, 36-month data, again, just recently published, it's a bit mixed here. Let's start with weight. It agrees with what I just showed in terms of you're seeing drops in weight associated with medication treatment and then catch-up, although you never really get all the way back to where you were previously. If you look at the height, it's a little bit more confusing. Most of the different groups are showing no changes, one of the consistent medicine showing some drop and then stabilize. It's hard to determine what you see there. Again, in our naturalistic data sets from our group, both boys and girls followed 10 to 15 years out, we do not see height or weight effects of the medications. But again, I have to tell you that most of the patients we treat don't stay on their medicines 365 days a year. Many of them are coming on and off their medications, which may be accounting for that. What do we recommend for growth? Periodically monitoring height and weight in all patients with ADHD medications. Get a baseline before you start treatment. Measure height and weight approximately every 6 to 12 months to let you know where you're at. Talk about the weight issue with the parents. If you're starting somebody on the medicine, parents are very concerned about the potential loss in weight, and they need to know that that's going to be expected for the first few months of treatment. Be consistent with measuring height or weight. You should be surprised in how many times in studies, for example, when we look at the data, we found that children actually shrank during treatment, in part because the first measurement was made with shoes on and the top of the scale wasn't properly adjusted, and subsequently other ones weren't. So always have the consistent way of checking height and weight. Shoes off, coats off. I don't make the children undress for their height and weight, but at least to have the major bulky items out. One of the biggest issues that comes up is what are the effects of giving younger children stimulant treatment in terms of the risk for the development of substance use disorders. It's an area they've been doing a lot of work on. We studied this as there have been a number of studies. We've looked at this ourselves. There have been a number of studies around the country. Michael Hughes has done a number of studies in Germany, and his study was included in this, and there have been studies subsequent to this meta-analysis. But when we reanalyzed the data, we found, in fact, that there was not evidence that stimulants increase the risk for substance abuse or dependence. Number two, we actually found a protective factor, that there was a reduction in the risk for substance use disorders, and in fact that risk was about almost 1/2 the risk in treated ADHD kids compared to untreated. That's the good news. The bad news, and what some of the longer-term studies are showing, is that effect tends to be most substantial in adolescence, and you start to lose that effect into adulthood. So in many cases, people stop the treatment into adulthood. And the risk factor time that you'd be most concerned about is from 17 to 24 years of age, which is when the children with ADHD are at the heightened risk for the development of substance use disorders. This is just showing you that we looked at characteristics of misuse and diversion in our samples also, and we found that 20% of our sweet little angels in our clinics, who we've been treating for years, were misusing their medications, getting high on their medicines. 11% were in the States. People are pushed to be capitalists and entrepreneurs in some ways, and 11% were selling their medications. I think they were doing it a little bit early in life to be entrepreneurs, but nevertheless they were capitalizing on it. So we know that this is an issue, but we also know that these were all children who had conduct or substance use disorders, which the epidemiologic data show. And also, all of this was with these very short-acting stimulants, not the extended release. And there have been a number of other studies demonstrating lower abuse liability of the extended release stimulants compared to the immediate release stimulants. So we are pushing in our country more and more to use extended release over the immediate release for a number of reasons, one of which is the abuse liabilities. Sudden death continues to be an issue that recirculates. This initially hit Canada with mixed amphetamine salts being pulled from the market and subsequently reinstated, and then the United States with some advisory board members asking for special precautions. Subsequently, that was not endorsed by the Food and Drug Administration. I just want to point this out right here, and that is the risk for a catastrophic sudden death to occur on the stimulant medications, and it turns out atomoxetine included in this, is between 0.2 to 0.5 per 100,000 per year. If you look at underreporting in this sample, and that would be estimated to be about 50% based on a Lancet article, you can find that the rate of sudden death, presumed to be cardiac, is about 0.4 to 1 per 100,000 children per year. If you look at the baseline rate of sudden catastrophic death in children, that same age group, it is between 1 to 8 per 100,000 per year. So the rates of sudden death on the stimulant medicines are at or below the rates of sudden death in the general population. Ergo, we don't think that there's an association with medications and cardiac effects. Nevertheless, the American Heart Association sort of leads what we're doing, and reasonable recommendations to screen for people who may be at risk for sudden death just by nature of having underlying structural cardiac deficits, personal, congenital, or acquired disease. The thing to ask about is palpitations, chest discomfort, syncopal or dizziness that's occurring, post-exercise symptoms, family history of premature cardiac disease, get a sense of what other medicines they're on, and perform a routine medical examination, blood pressure and heart rate. No electrocardiogram is necessary. You don't need to do graded exercise tests. You don't need to do echocardiograms. You don't need to get cardiac biopsies. Okay, you just do the clinical symptoms of these structural lines. If they're positive, refer those individuals. An adult, you're going to do a workup as indicated based on their past history. And if you have somebody who has something, a history of idiopathic hypertrophic subaortic stenosis, which is probably the number one risk factor for sudden cardiac deaths in children, those people are going to need very extensive workups. We do not discuss sudden death during our routine risk and benefit ratios when we talk to patients about these medications. It's very hard to say these medicines can cause dry mouth or sudden death. Atomoxetine is among first-line agents. It's a specific noradrenergic agent. It has effects on dopamine in the frontal lobe and norepinephrine elsewhere. It's not a controlled substance. It has no abuse liability. It's really absent entirely abuse liability. There have been multiple controlled trials and 5 currently in the European arena. The long-term studies show continued effectiveness and good tolerability. And there have been a number of 3 and coming up 5-year follow-up studies. Here you can see the dose response and a reduction in ADHD symptoms. This is at atomoxetine 0.5, 1.2, and 1.8 milligrams per kilogram per day. Here you can see that this is similar to this. In other questions, kind of other areas of ADHD, you actually see better improvement in the 1.8 over the 1.2 milligram per kilogram per day. Another important point is, if you analyze these data further, notice that those who respond the best to treatment, here the more negative, the farther down you are, the more negative, the better improvement you have, are that group that were stimulant naive. So this compound works better in children who have not failed 2, 3, or 4 different stimulant trials. And another important point is, in my opinion, this is one of the most important findings with atomoxetine, is it's an anxiolytic. It has very powerful effects on anxiety. And ADHD runs with anxiety. 40% of children with ADHD have anxiety. And I'm sure you can pose some very interesting questions to Professor Tannick, who really helped us understand some of the important neuropsychological overlay in those anxious ADHD children. Nevertheless, this medication improves, as we've shown, as had been demonstrated previously, improvement in ADHD. But this is in anxious ADD children. It also improves effects in anxiety, more substantially than I've seen with any other compound used for ADHD and anxiety. So when do you use atomoxetine? It can be used as a first-line treatment, and again, useful in naive patients, stimulant non-responders, those who are partial responders. And I'm going to talk tomorrow about using it in combination with stimulant medications. What happens when you use atomoxetine plus stimulants? You have to wait till tomorrow. Adverse effects to stimulant medications, those individuals who are diverting, selling their medications. And then comorbidity, this list goes on. I took out a slide. We have very interesting data that shows if you treat recently abstinent alcoholic adults with ADHD, with atomoxetine compared to placebo, you see improvement in ADHD. By the way, that's the first time you can show that in juxtaposition with active substance abuse. But more importantly, over the 12 weeks of the study, an almost 30% reduction in alcoholic drinking. That's the good news. The bad news, everybody relapsed. But the good news is they drank 30% less over the 12 weeks of the study. Again, a signal there that we need to do more studies in that population because of that overlap. Careful in bipolar youth, it can, like all noradrenergic and catecholaminergics, can lead to activation. How do you dose it? Start low, dose up. After 6 weeks, if you have a partial response, considering going to 1.4 to 1.8 milligrams per kilogram per day. And again, we've talked about the monitoring. And the side effects that you see are listed: somnolence, appetite suppression, upset stomach, blood pressure issues. Careful with certain drug interactions such as paroxetine, fluoxetine, or if you're using the antifungal agents, ketoconazole. You have rare problems with such as suicidality, hepatotoxicity, only a couple of cases. Cardiovascular, monitor blood pressure, no major outcomes there, and aggression and hostility, like you can see with any of the medicines we use for ADHD. And here's a list. This is in case you're having difficulties with jet lag sleeping. This is potent soporific effects to go through this, but you can see a list of different side effects that can emerge. I'm just going to go a little bit quicker through the last few slides. Tricyclics we have used for years. They continue to work for ADHD. They continue to have response rates of around 60 to 70%, which are pretty substantial for this condition. Problems, cardiac side effects, problems, overdose, even in the individual in whom they are prescribed or their brothers or sisters. Bupropion, which is available in many of the countries, is a mixed catecholaminergic reuptake inhibitor. It has a stimulant-like structure. In fact, on drug testing, it may come positive as amphetamine and has no known cardiac conduction problems. It's been demonstrated in only one trial for children. Actually, it's more substantial finding. We just published the extended release data in adults. It improves attention and behavior, not just behavior. Some people think it's just behavior, but it actually it improves all different domains. This is an area that I think its life is for moody adolescents and moody adults. For example, in this paper, published showing it improves ADHD in adults with bipolar disorder who have bipolar 2. These mood labile adults, not severe bipolar, but more minor bipolar with ADHD. Finally, the antihypertensives are continuing to be used, and there's some more interest in them. Just looking at clonidine, which is an alpha-adrenergic agent, dosing up to 0.2 milligrams 3 times a day. You can see there have been 3 controlled trials, multiple open trials. We're using it not only for ADHD, but for aggression, impulsivity, ADHD-related sleep disorders. It can be a very good sleep agent, and it helps with mainly hyperactivity, impulsivity, although there's some recent data showing improvements in cognition when you look carefully. Side effects are sedation, depression, rebound hypertension. There's some controversy about use with stimulants, but again, we don't think that that's of major concern. Finally, I'd like to just tease you with 2 things to think about. This is like clonidine. This is guanfacine, alpha-2. One of the problems with these agents are that they have to be repeat dosed. These can be very helpful for kids with movement disorders and ADHD. I know there have been a number of talks on Tourette's and tic disorders with ADHD, and these agents can be very helpful. Larry Scale, who is here, presented, has shown one study, for example, with multiple dose guanfacine and methylphenidate to be improved. But this is a new once-a-day guanfacine, extended release once a day that's going for full approval in the United States. I wouldn't be surprised if that passes to come over to Europe because of its multiplicity of uses in both movement-disordered ADHD as well as primary ADHD, along with other areas. So stay tuned, and it's going to be an improvement because it's just a once a day as opposed to multiple daily dosing. And finally, an area that I'm very interested in, twice the risk of cigarette smoking across the lifespan with ADHD. That early studies showed that nicotine itself put on somebody, nicotine patch or smoke, improves attention. All the studies show nicotine improves attention, but here it improves it in ADHD. This is the first generation, and subsequently we published the second generation studies with nicotinic modulating agents now. These work on the nicotinic system, not the classic catecholaminergic system, but increase nicotine neurotransmission, increase direct stimulation. Where that's occurring and why it's improving attention is under investigation. But here you can see a study previously that showed improvements with this ultra-short-acting nicotinic agent compared to placebo. There are a number of studies underway right now further looking at this class of agents. And I think these are going to be particularly interesting for many of the cognitive and executive function deficits that you see in ADHD. They improve at hyperactivity and impulsivity. But where you're hearing qualitatively about these medicines working is in some of the cognitive deficits, as you heard about from Dr. Tannick, and the importance of that. So in summary, pharmacotherapy is one of the mainstays of treatment for ADHD, mixed with all of the things you've heard previously, the stimulants, atomoxetine, arousal agents. Didn't talk much about modafinil, but can answer questions about that. Antidepressants and antidepressants have all been demonstrated under controlled conditions to be effective for ADHD. The adverse effects to the medications are generally manageable. Thank you very much. As we do this question, if the panelists could come forward, I'd appreciate it. We have an ARS question, the last of the questions here, and that is, which of the following medications have not been shown to be effective in ADHD? Great answers. These are for me. Do they have theirs? Okay. Rosemary, do you want to start when it comes to the questions? Well, I have to tell you, this is terrific that people were listening. I want to know who voted for 1, 2, and 3. All right, that's...